On behalf of the Palliative Care Outcomes Collaboration, or PCOC, thank you for watching this video today on PCOC fundamentals. I'd like to acknowledge the traditional owners of the lands on which we meet and pay respects to elders past, present, and emerging. I would like to extend my respect to Aboriginal and Torres Strait Island people, colleagues, and staff who are with us today. Welcome. In this session, we are focusing on the fundamental concepts of PCOC and how to use each of the 5 PCOC tools to assess and respond to the needs of palliative care patients, their families, or carers. The fundamental principle of PCOC is the routine assessment of patients and their families or carers using PCOC's 5 validated assessment tools. Depending on the scores from those assessments, treatment and interventions are actioned. Assessing at every contact allows you to review the previous assessments, evaluate the current care plan, if it is working, and if required, create and document a change to the patient care plan or clinical record to meet or anticipate the patient or family's changing needs. PCOC supports patient care in a number of ways. It establishes a common language to enhance and streamline communication between palliative care providers and facilitates seamless transition between care settings. It includes patient-reported outcomes measures to deliver needs-based, person-centred care for patients, carers, and their family. It provides information on the resources that are required to be able to provide care for patients and support carers and families. It also includes the holistic assessment of physical and psychosocial needs that drive the focus of care. It acknowledges the family and carer as part of the unit of care and how family care and needs may influence and impact on the patient. And it also establishes and standardises not only the assessments conducted for each encounter, but also the expected responses and the urgency in which these responses should occur. There are 3 levels of information collected by PCOC. This information works together to describe patient outcomes. The patient level reflects the demographic information. It is collected as part of the administrative processes in the admission of a patient. Episode is about the location of the patient and the type of palliative care service. And then the phase level. This is about the clinical needs of the patient and family. To capture this, 5 assessment tools are used. Today, we are focusing on the phase level. That is the 5 PCOC assessment tools. Using PCOC leads to better patient experiences and improved outcomes of care. Some of the benefits for patients and families are that the unique needs of patients are routinely assessed. Patients, families, and carers are part of decision-making, which enhances communication with clinicians. And services are able to consistently measure the care they provide, which allows for continuous improvement. The benefits for clinicians are introducing validated assessments so that patients can be assessed consistently, and these are the vital signs of palliative care. It establishes a common language for communication in and between teams and across settings where palliative care is provided. It establishes a baseline assessment or snapshot of needs, of which you can compare to in the future and measure improvements or declines. And it provides a consistent and accurate way to measure symptoms and problems so that these can be tracked and any variations can be responded to based on the patient's needs. There are other benefits which you may be able to think of too. Overall, the most important thing to take away is that PCOC assessments are used to measure, anticipate, and respond to patient and family care needs and to improve patient outcomes. The PCOC tools. PCOC uses 5 validated assessments to capture a holistic picture of the patient and their family or carer to inform the care plan and demonstrate outcomes. These are the 5 PCOC assessment tools with a brief overview of purpose. We have the palliative care phase that describes the patient and carer needs. The SAS, or Symptom Assessment Scale. This is a patient-reported screening tool that supports patient-reported outcome measurement. It specifically measures the distress of 7 common patient symptoms in palliative care. The Palliative Care Problem Severity Score is the clinician-rated tool used to screen the severity of 4 domains. And the AKPS, or Australian Modified Karnofsky Performance Scale. This measures the overall performance status on a scale of 100 to 10 and is based on observations of a patient to perform common tasks related to activity, work, and self-care. Finally, the RUG-ADL, or Resource Utilisation Group of Activities of Daily Living. This describes patient functional dependency and the resources required for care. These functional and symptom tools used together help to determine the palliative care phase and the needs of the patient and family carer. The palliative care phase helps to inform what response is required and the urgency of that response. The goal is to incorporate these assessment tools into routine practice and to use the assessments to guide care. It may be helpful to view the assessments as palliative care observations or vital signs. Assessments can be conducted in person or via the telephone. And the assessments can be conducted daily or at contact to detect changes in patient and family carer needs. The 3 points of assessment on this slide gather the information about the patient's outcomes, their admission to palliative care, change in patient and family condition, which is the phase change, and at discharge. A common error is not assessing the patient on discharge. Without this information, patient outcomes at discharge of your service are unknown. And when a patient dies, no further assessments are undertaken. We're now going to work through the symptom-related tools. The Symptom Assessment Scale and the Palliative Care Problem Severity Score tools assess the symptom distress and problems of the patient and their family carer. Let's take a look at the SAS first. The Symptom Assessment Scale measures the patient's level of distress from 7 common symptoms in palliative care. These are pain, fatigue, breathing problems, nausea, difficulty sleeping, bowel problems, and appetite problems. There is also a blank space at the bottom of the SAS tool on the episode form to add other distressing symptoms or problems that may be tracked and assessed over time. These are specific to your patient. It is important to note that this is a patient-reported outcome measure and should be completed by the patient. The communication between the clinician and the patient is about seeking from the patient what their level of distress is. It may be through an informal conversation weaved into usual care, like ADLs, or may require using other words which best suits the patient's understanding of distress, such as bothersome, worry, or concerned. Using the SAS, you can identify the effectiveness of clinical interventions from the patient's perspective, as well as measure changes in symptoms, improvements, or declines. It also further identifies the patient's priorities in terms of distress, tracking individual symptoms over time, and ensuring that the care you are delivering is focused on what is important to the patient. The SAS tool describes the patient's level of distress relating to individual physical symptoms. It is designed to be a patient-rated tool, but also allows for rating by proxy. For accuracy and consistency, it is best for the patient to score symptoms on their own using the Symptom Assessment Scale form for patients. It's important to explain the SAS to the patient, what is assessed and why. Using the SAS gives patients the opportunity to voice their distress about the symptoms and help plan their care. PCOC has a few resources that can assist patients with understanding the tool and supporting them to rate their own symptoms. It's also been translated into the 14 most widely spoken languages in Australia. Instruct the patient to consider their experience of the individual symptom or problem over the last 24 hours or from their last assessment, and rate according to how severe distress has been. A score of 0 means the symptom or problem is absent, or there is no distress associated with that symptom or problem. A score of 1 means the symptom or problem is causing minimal distress. A score of 10 means a symptom or problem is causing the worst possible distress. It's important to note that the degree of distress may not relate to the clinical severity or presence of the symptom. For example, a patient may have a poor appetite but does not experience any distress relating to appetite. The two items that cause the most confusion are appetite and fatigue. When assessing appetite and fatigue, it is important to consider, is it a problem for the patient? And if so, who has the problem? Is it the patient, carer, or others? For example, in general, appetite is reduced as people get sicker. In the terminal phase, the patient is not interested or unable to tolerate food. This is a normal part of the terminal phase and is unlikely to cause distress to the patient. The same can be said for fatigue. In general, fatigue does not cause distress for the patient in the terminal phase. However, the carer may be concerned about one or both of these symptoms. In the terminal phase, low SAS scores for appetite, difficulty sleeping, and fatigue are expected. If a carer is distressed about appetite or fatigue, these concerns can be included in your palliative care problem severity score by recording moderate or high for family carer problem severity. A patient may not be able to communicate the degree of distress if they are unconscious or experiencing confusion or delirium. If language or other communication barriers are present, you should consider using an interpreter, a visual scale, or descriptive scale. Some patients, even with a level of disorientation or confusion, may be able to respond to this assessment. Please offer your patient the opportunity to respond to these symptoms before defaulting to proxy assessment. A question PCOC commonly receives is, what do I do about assessing symptom distress if the patient is confused? The answer is, if the patient is confused, there is still a chance that he or she will be able to report their symptom distress using the symptom assessment scale. So the opportunity to do this should be provided. When an inability to comprehend what is required is demonstrated, it will be necessary to then resort to proxy scoring, or if unable to complete, document as not assessed, or NA. The key message for SAS: it is important, where possible, to seek from the patient how they are feeling. That is, if any symptom is causing them any level of distress. And this may be achieved in conversation, providing a PCOC ruler, or the SAS form to assist them in rating their distress, if any. The palliative care problem severity score is a clinical tool, and this is our next tool. This tool is used for initial screening and ongoing coordination of care. It is clinician rated, and it includes global assessment of 4 palliative care domains. These are pain, psychological, spiritual, other symptoms, and family carer. The overall severity of problems for each domain is assessed by the clinician through discussion with the patient and family carer and through observations. Please note some of the symptoms or problems on this slide that the patient or family carer may be experiencing in each domain. This may help you in your assessment. And note that this is not a distress tool, but a measurement of overall problems that trigger a clinical response based on the severity. You may ask yourself some of these questions to help you in your assessment using this tool. Is the patient experiencing any symptoms? If so, what is the overall severity of the symptom or combined symptoms? Also, is the patient experiencing psychological or spiritual problems? How much of a problem are the psychological or spiritual issues? And are the family or carers experiencing problems, and what are the severity of these problems? A severe rating or 3 for family carer may trigger referral to social work or pastoral care. Some common questions we get with the palliative care problem severity score. What do I score if there is no family? And the answer is you score a 0 or absent. Another question, if the family are not physically present or rarely involved in care or decision making, how do I make an assessment? The answer, you use any information available, such as phone conversations, documentation, communication with the patient about the family, and any other sources for you. In this case, the rating could be high, as limited contact may be related to one of the examples that are on this slide above, which then causes distress and problems or issues for the patient. And finally, what kinds of responses can this tool trigger? Well, a response may include referrals to other health professionals or members within the caring team, further or deeper assessments, and or other interventions. How do we assess? Generally speaking, the palliative care problem severity score is often linked to the following responses. A score of absent or 0 means no further action is needed. A score of 1 or mild means to monitor the patient and family. And a score of 2 is moderate. And this means review and discuss with the team. Finally, a severe score of 3 means urgent action. Let's go through some of these actions now with each of these scores, and also looking at the SAS as well. So a palliative care problem severity score of 0 for any of the domains and a distress SAS score of 0 for any of the symptoms would tell you that the patient has no problems or symptoms and does not require a change in the care plan. So it means that the present care plan is working and no changes are required. In this instance, the phase may be stable or terminal if all scores are 0. Actions for SAS with scores of 1 or 1 to 3 and palliative care problem severity score. So for the palliative care problem severity score, a score of 1 for any of the domains and a SAS distress score from 1 to 3 for any of the symptoms would tell you that the patient's problems or symptoms are currently managed by the existing care plan with some inclusion of an interventional treatment with the goal of care to score 0 at the next assessment. The phase could be stable if the care plan is being amended from within the current care plan and anticipating needs. It could also be deteriorating if patient or family needs are not being met in the current care plan. These needs are not urgent, but a change is required to support the changing requirements of the patient and or their family, and such needs can be addressed within days or weeks. The phase could be terminal if death is likely within a few days and the patient has some symptoms or problems from the scores on the palliative care problem severity score or the SAS. If all scores are 0, the phase may be stable or terminal. This means the care plan is effectively meeting the needs of the patient and their family. Moderate scores and what they can trigger. A palliative care problem severity score of 2 for any of the domains and a distress SAS score between or on 4 and 7 for any of the 7 symptoms would tell you that the patient's problems or symptoms require a change in the plan of care, if not already anticipated in the plan. And referral and escalation is required to address the symptom or problem in a timely way. Document the existing care plan that it is not working and a change in the intervention or treatment is required. The phase here could be deteriorating if it is considered that there needs to be a change in the current plan within the next few days or weeks. It is not urgent, but it is anticipated a change will be required from the outcome of the referral. The phase will be terminal if death is likely within a few days and the patient has symptoms or problems as indicated from the scores on the PCPSS or the SAS. These problems or symptoms require a change in the care plan to address or minimise those symptoms and problems. And actions for higher scores. So palliative care problem severity score of 3 for any of the domains and a SAS score from 8 to 10 for any of the 7 symptoms would tell you that the patient's problems or symptoms require an urgent change in the plan of care, if not already anticipated in the plan. And referral and escalation is required then to address the symptom or problem. Document the existing plan of care is not working and a change in the intervention or treatment is required. The phase will be unstable if, with these high assessment scores, there is no anticipated action or contingency for such an escalation documented in the existing care plan. An unstable phase is considered urgent in response, and thus there needs to be a change in the current plan within days. With these scores, the phase will be terminal, or could be terminal as well, if death is likely within a few days. Respond to these scores appropriately by adjusting the plan of care to resolve or mitigate the symptoms or problems that are causing the issue. Here is an example of PCOC's assessment and response framework, and it's available on a lanyard. The functional assessment tools. The resource utilisation group, activities of daily living, and the modified Australian Karnofsky are the two tools in the PCOC assessment suite that assess the patient's functional dependency and their overall performance. The patient's RUG ADL score, if we start with the RUG, is an indication of the functional status and, in most cases, the amount of care and support required. It measures function across 4 different domains. We have bed mobility, meaning the ability to move in the bed after the transfer to the bed has been completed. For example, how the patient may perform spontaneous movement and their own pressure area relief within the bed. Toileting includes mobilising to the toilet, adjusting clothing before and after toileting, and maintaining perineal hygiene without incontinence or soiling of clothes. Transfer includes the transfer in and out of bed, or bed to chair, or in and out of shower. Eating includes the cutting of food, bringing food to the mouth and chewing and swallowing of the food. It does not include meal preparation. The RUG ADL is assessed by what the patient is actually doing, not what they are capable of doing. It's best to get a correct answer to this question or for this tool by asking the following questions. Do you, rather than can you? For example, the patient may be physically capable of transferring themselves from a bed to a chair, but they do not currently do this as it is very physically demanding on them and can put them at risk. As such, they regularly call on their carer or family member, and so the score needs to reflect this care input. And as I mentioned, the RUG ADL score gives us an indication of the resources required to care for the patient, and so it can be used to determine these following aspects of care. The level of home supports needed or suitability of aged care facility placement, albeit low or high level care. Staffing levels required to care for the patient, discharge planning, handover to summarise functional condition, and it's also really useful in creating that common language in palliative care. To score the RUG, you first assign a score for each of the domains. For bed mobility, toileting and transfer, these scores are 1, 3, 4 and 5. 1 indicates that the patient is independent of their activities in that particular domain. For example, for bed mobility, they can adjust their position in the bed and they do not require any hands-on assistance. A score of 3 indicates that they require limited physical assistance to be able to perform the activity. With limited physical assistance, this means hands-on assistance of 1 person. A 4 indicates that the patient requires the assistance of 1 person and a device. For example, with bed mobility, they may need a hoist and the hands-on assistance of 1 person. And a score of 5 indicates that the patient needs 2 or more people to assist with performing the task. So why is there no score of 2? There is no score of 2 for these first 3 domains because it has been shown that the change from the independent supervision level to a limited assistance level equates to a threefold increase in resources rather than a twofold increase. So the designers of the tool are attempting to equate the scores to reality of the resources needed and time and devices. And finally, the eating domain. Here, the possible scores are a 1, a 2, or a 3, noting that if a patient is nil by mouth but requires mouth care, they receive a 3. Again, 1 indicates that the patient is independent for eating. A 2 means that hands-on assistance is required to assist in bringing food to the mouth. And a score of 3 means they require full assistance to eat meals, they do not eat or drink full meals, or they rely on enteral or parenteral nutrition and do not administer feeds themselves. A total score is then calculated, which gives you a picture of the overall functional status and dependency. When communicating with other colleagues, the total score is communicated rather than the individual score of each domain. Here's some actions for RUG-ADL. So some aspects to note for this tool is that as the score increases, the patient may be at high risk of falls and pressure areas or wounds. And also a carer may be at high risk of carer stress, fatigue, and burnout. Therefore, a RUG-ADL assessment can trigger referrals for allied health, for example, to occupational therapy for extra equipment, or to social work to assess carer burden. Here are key messages for the RUG-ADL. So it's important that we use the tool correctly in practice to support appropriate and reliable resourcing to reduce any risk to patient, family, or carer, and to support discharge planning as well. The Australian Modified Karnofsky Performance Status is our next tool. And this tool is a measure of the patient's overall function or ability to manage their own activities of daily living across 3 domains. It is a single score of increments of 10 between 0 and 100 and assigned by a clinician based on the observations of a patient's ability to perform common tasks. A score of 100 signifies normal physical abilities with no evidence of disease. Decreasing numbers indicate a reduced ability to perform activities of daily living. It can also be used to indicate prognosis and survival times, and it has been used in studies looking at patient trajectories. Do note that with this tool, there are no half or partway measures. For example, a 45 or a 32. And so if you are unsure of a score, please discuss this scoring with your patient if you're able to, their family or carer, or a colleague or your team. Here are some possible actions or responses to the Australian Karnofsky Performance Scale scores. So here we have a score between 100 and 80. While the patient's Karnofsky is still in the higher levels here, this may be the appropriate time to consider advanced care planning. Once the Karnofsky decreases to 70, the patient is no longer able to work or carry out other activities. If they have had to cease work, a referral for social work would be appropriate. As the Karnofsky declines further to a 60, a patient is starting to require a higher degree of physical assistance and medical input. Referral to an OT for equipment needs and or physio to support ongoing movement may be required. As the Karnofsky declines further to a 50, a patient is starting to require a higher degree of physical assistance and medical input. Other actions may include a review of the visit schedule, a review of carer burden, including the use of the CESNAT or another carer assessment tool, review falls risk, re-engage social work, review the end-of-life care plan, engage an EN or PCA for hygiene support and education, and offer respite if appropriate as well. A score of 40 on the Karnofsky means a patient is bedfast or otherwise sedentary in a chair or lounger, for example, and this is more than half of the time. These patients are at greater risk of pressure area wounds and falls. Here you can consider a multidisciplinary team discussion and review of the care plan to anticipate the patients and their carers' needs and resourcing. A Karnofsky of 20 or 10 indicates that the patient is completely dependent and may be comatose. Using this score and other clinical indicators, you may decide that death is imminent, in which case you would commence end-of-life care planning and assess the patient in the terminal phase. Here are some of the key messages for the Karnofsky and some of the questions that you can use or ask yourself when assessing the Karnofsky with your patient or family. Now we're at the palliative care phase and using the palliative care phase in your routine practice. The palliative care phase helps identify the needs of the patient. It determines the frequency of assessment and urgency of reassessment. It supports referral and triage, and also determines the appropriateness of palliative care. The phases were based on these principles. In palliative care, the focus is on the patient's needs, goals, and priorities rather than the disease. In palliative care, the patient and their carers and family are the unit of care. And the palliative care patient may have episodes of care that includes acute exacerbations, and such episodes are applicable to both the home or hospital setting. There are 5 palliative care phases. 4 of these are used by PCOC. A key aspect to note is that despite the numbering of 1 to 4 for these phases, the phases are not sequential, and that patients can skip between any 2 phases as determined by their needs. So what are the phases? Firstly, we have stable. There are no new needs, and what you're doing for the patient and family is working. You have also anticipated changes for the patient's condition or diagnosis and incorporated such actions into the plan of care. The unstable phase. Here there are new needs or sudden changes in the needs of the patient and or family. An urgent change or update is required. Allow time to ensure the care plan is working before the patient, family carer, are moved into another phase. We then have the deteriorating. The patient and family have increased needs that are not urgent or were anticipated in the care plan but not fully meeting the patient or family carer's needs. Adjustment therefore needs to be made to the care plan with time in this phase to ensure the changes are appropriate and working. And the terminal phase. Here the patient is likely to die in a matter of days. The terminal phase takes precedence over all of the other phases if death is likely within days. Continue to use and review the other assessment tools to meet the patient or family carer's needs as they arise. So the key point for the stable phase is that a patient in a stable phase has adequate symptom control and the patient, family or carer needs do not require a change to the plan of care. Stable phased patients could be medically deteriorating, but their needs and changing needs are being met from the care plan. Patients who are in the stable phase are thus not unstable, deteriorating or terminal. The stable phase may be used as a trigger to discharge a patient or review the frequency of medical assessments for community visits, for example. Some questions we commonly get at PCOC are, can a patient's condition or disease progress and still be assessed as stable? And the answer? Yes, the palliative care phase does not reflect the medical condition of the patient, but rather the need for interventions and changes in the management plan. Interventions can occur during the stable phase as long as the management plan remains the same and no urgent treatment is required. Another question, what phase should I assign if I assess my patient as stable, but the patient's carer is experiencing a sudden change in their situation, such as emotional distress, and this requires urgent attention? The answer is you would assign a 2 or unstable. The carer's distress will be reflected then in the palliative care problem severity score. Some actions for the stable phase. In the community, you may also look to decrease the frequency of visits or to change the mode of care to phone calls instead of face-to-face visits. The unstable phase. Urgent refers to changes in the care plan and interventions that need immediate attention. Examples may include medical review, palliative care consultant review, referrals for urgent action, tests and procedures, and medication changes. Assessment of a patient as unstable could be used as a trigger for palliative care consultant review. A question we commonly get around the unstable phase is the patient is not experiencing any symptoms or problems that require a change in management, but the family requires urgent intervention and a change in the care plan. Is this patient assessed as stable or unstable? And the answer is unstable, because there is a worsening severity of problems relating to the family that require urgent interventions. And the palliative care phase reflects the unit of care. An unstable phase can be finished if the review establishes that the care plan is working and that no further changes are required. This does not necessarily mean that the problem or symptom is resolved, but the palliative care problem severity or the SAS scores are showing lower scores and providing evidence that the plan of care is working and effective. The deteriorating phase. This phase may trigger interventions such as referral to a physiotherapist for mobility, social work for the family, and pastoral care for the patient or family. These interventions are not urgent, as in the unstable phase. For example, the addition of a new medication for an existing symptom or an expected worsening of a symptom such as nausea. Here are some actions for the deteriorating phase. So changing the plan of care to address the increasing needs and a referral to allied health. The terminal phase. Here, death is imminent as evidenced by other clinical signs such as breathing changes, changes in the skin colour, fluctuating levels of consciousness, and limited oral intake. While these signs may also be present for months in patients with dementia, and even the normal ageing process, the key question is to ask, is death likely in a matter of days? A common question PCOC gets is, does a rapid increase in current symptoms or new symptoms put a patient who are currently in the terminal phase into an unstable phase? And the answer is no. If the patient is likely to die in a matter of days, they remain in the terminal phase, but do continue to assess, monitor, and respond to the other PCOC assessment tools. And here are some actions for the terminal phase. If not already, commence end-of-life care, communicate changes to family and other significant others for the patient. You may then also move the patient out of the terminal phase if the patient is no longer likely to die within days. And if the patient does die at the end of the terminal phase, then you would end the episode of care. Now, some case studies to close this webinar today. Let's take a look at this first case study. And if available, please have your lanyard or a copy of the PCOC clinical manual handy. And consider these questions and your responses for Mr. Jones. What are the correct SAS scores for Mr. Jones in relation to pain and nausea? What is his RUG ADL score? And what could be his palliative care phase? So Mr. Jones is a 76-year-old male diagnosed with lung cancer with cerebral metastases. He lives at home with his wife, Mrs. Jones, and she is the primary carer. Mr. Jones is complaining of a headache. He rates his distress from pain as a 6 out of 10. Mr. Jones has required 4 times endone, 5 milligrams in the past 24 hours. He has not been prescribed any sustained release medication and is not currently taking steroids. Mr. Jones also reports his distress from nausea is a 5 out of 10. His mobility has reduced and he is now almost completely bedfast. His RUG ADL is 14. Mrs. Jones reports she is really having a hard time managing his needs. She feels like he'll probably need to go to hospital in the coming days. So considering the questions again, what are the correct SAS scores for Mr. Jones in relation to pain and nausea? What is his RUG ADL score? And what could be his palliative care phase? To summarise the answers, Mr. Jones has a SAS pain distress score of 6, and his nausea is creating a distress score of 5. His RUG ADL total score is 14, and his phase is deteriorating, with these possible outcomes described on the slide by setting of care for both community and inpatient. A few days later, Mr. Jones was admitted to a palliative care unit at the local hospital. His pain and nausea is now well controlled. However, Mr. Jones continues to decline and he is now unresponsive. Mrs. Jones has become visibly upset and reports being surprised by the sudden deterioration. She responds well to support from the nursing staff. Here are some questions to consider. What is the correct phase? And what is the correct palliative care problem severity family score now? So what is the correct phase and what is the correct palliative care problem severity score for family carer now? We found the palliative care problem severity score for family carer to be a 2 or moderate and assigned the terminal phase to Mr. Jones and his family. Putting this all together now. So if we had an assessment for the community visit, the main problem for Mr. Jones was pain. He scored a 6 on the SAS. He also rated his distress from nausea as 5. And if we recall, this was causing his wife, his main carer, some concern as she felt she may not be able to care for him at home and as he may become more dependent as well. Mr. Jones required help with the use of walking and bathroom aids at home. He's then moved into the inpatient unit, and these are the assessment scores on admission. Mr. Jones is admitted to the palliative care unit as he has become more dependent and his wife could not assist him. So the community episode ended with a discharge to the palliative care unit. The inpatient episode unit then starts with the assessment scores on admission captured here. So this slide or image is how the PCOC tools can be used at handover too. Reflect upon the picture that you can see and that you've also developed in your mind as you consider Mr. Jones and his case study. And this type of handover information, is this format helpful? If not already, can it be implemented into your services or team's handover? This brings us to the conclusion of our webinar today. In summary, PCOC is a national program that aims to introduce and embed standardised and validated clinical assessments in palliative care. That is, everyone is using the same tools to assess patient needs in palliative care. PCOC aims to embed nationally standardised clinical assessments and point-of-care data collection into daily practice. The data from the tools is used in real time for planning and delivering patient care. PCOC helps palliative care providers to identify and measure care and the effectiveness of the team communication, interventions, or actions too. PCOC reports and benchmarking are used to drive improvements in patient outcomes and evaluate service effectiveness. We can review the impact of service delivery on people with a life-limiting illness, their families, and their carers. Thank you for your time today. If not already, we welcome you to visit our PCOC website and complete the PCOC Essentials program or self-directed packages. Finally, please contact your local improvement facilitator if you have further questions or seek further support. See you next time.